the East. Good evening. My name is Laetitia Rispel. I'm Professor of Public Health at the University of the Witwatersrand in Johannesburg, South Africa, where I also hold chair on the health workforce. I'm one of the partners in the AFRHiCARE research program, and I'll be your host this afternoon and host this webinar. So just by way of introduction, I'm delighted to welcome all of you to the webinar, which focuses on gender and intersectional analysis in health systems research. To tell you very briefly about the AFRHiCARE partnership, it's a 2023 Wellcome Trust Discovery Grant, which brings together a multidisciplinary team of lead researchers from Oxford University, Professor Michael English, and Associate Professor Jeffrey Wong. I'm not sure if they're on the webinar, but they'll be joining us probably a bit later. From Makerere University, we have Professor Freddie Singoba and Dr. Raymond Tweyu. And then we also have senior scientists from the KEMRI-Wellcome Trust. But since the commencement of the partnership, we already have more than 20 team members. So this afternoon, we're going to focus on gender and intersectional analysis in health systems research. AFRHiCARE, the AFRHiCARE partnership, AFRHiCARE is an acronym that stands, as you can see on the screen, it stands for Africa's First Referral Hospitals, Innovation and Care. And the care, we sort of play around with the term care. It could mean both care for the for health workers, the health workforce that are central to the functioning of first referral hospitals. It could mean care for patients. It could also mean care for the environment. And of course, care for issues that are close to our hearts, like gender and climate change. So AFRHiCARE envisions more resilient health systems. We recognize that the health workforce are the personification of health systems, but are also central to the achievement of universal health coverage. And we also recognize the critical role of gender, of technology and climate change in realizing our vision. This afternoon, we've put together a webinar. It's actually our first webinar, so we would like to get your feedback on it. We have 4 panelists that are going to share with us not only the research that they've done, but also the insights from years of research and work in their respective fields of expertise. Just before I introduce the speakers, I would like to just make a few announcements. We're asking that you introduce yourself in the chat box. And Yingxi, who I'm going to introduce in a short while, he's my colleague from Oxford University, and together the two of us have conceptualized this webinar. But I must say that Yingxi Zhao actually did all the work for the webinar. During the question and answer session, because we only have 90 minutes, that can go very quickly, we are not going to have any live questions. So we're asking that you post any questions that you have in the question and answer box. We're going to start with those questions that some of you have asked us already at the time of introduction. We are recording the event, so if you're unable to stay until the end, or if you want to watch it later on again, you'll be able to get it on the AFRHiCARE webpage, and we'll post that right at the end of the webinar. And just the last announcement from me, I'm going to introduce each speaker. Before the person speaks, I will then turn off my camera, so the only attention will be on the speaker. And after 10 minutes, I will put my camera back on, and that'll be a cue for our speakers that they need to wrap up the presentation. Just lastly, on the screen, Yingxi is going to just show you the program for this afternoon. And I've already done my introduction, and it gives me great pleasure to introduce our first speaker, who's Dr. Bintu Mansaray. Dr. Bintu is originally from Sierra Leone. She's a medical doctor, a public health specialist, and a social science researcher with more than 6 years experience in health systems, women's health, and safeguarding. She currently leads the gender-focused research in Sierra Leone, and she's the founder of the Institute of Gender and Children's Health at Bristol University. Without further ado, Dr. Bintu is going to talk to us about balancing roles, navigating the intersection of gender and medicine in African hospitals. Over to you, Bintu.
Thanks, Laetitia. Thanks for the invite and thanks for the introduction. So welcome, everyone. I am Bintu and I'll be kickstarting this talk. So thanks for being here. Next slide. So this is basically a brief run through. Since I'm starting, I just want to talk about my position. I felt it was best to talk about my position as a woman, a mom, a wife, a medical doctor, a researcher who has worked in African hospitals, in different African hospitals, just to situate the conversation. And hopefully we'll move on from there. Next slide, Lindsay. Thank you. So we all know what gender analysis is, why we're here, and how important it is in health systems research, but even in the designing of hospitals to ensure that women have access, to ensure that labor roles, decision-making is distributed. But obviously, it is not how it should be. And other speakers will talk and show you statistics and data about what all of that means. And I will talk about reflections, basically. Next slide. So I'm going to start back to the Ebola outbreak, because when I think about where gender comes in for me as an African doctor was during the Ebola outbreak. At the time, I wasn't married. I had no kids. I was working in a non-governmental hospital. It's like an NGO hospital, Emergency. It's an Italian NGO, and it was very well equipped. We had all the IPCs we need to work. And I felt that there was no reason for me to stay home. And I was working just as I usually do. And then I noticed that all the female doctors, the married doctors, were slowly stopping work because their husbands, their families were telling them not to go to work anymore. And that brought to mind that I could go to work because I had no one to tell me not to go to work, even though my mom did. And there was a whole family meeting about that. But then I had no one else to think about besides myself. I could isolate myself in my room. I had no small children. And even though we had everything, at the end of the Ebola outbreak, I started thinking, what else would I have wanted? And I was working in a well-equipped for an African setting hospital, which my counterparts and my friends in government hospitals, they did not have what I had. But then I still felt the mental health stress of working during that period, as anyone can imagine. Next slide. And this brings me then to the next point, my experiences as a new mom. So the Ebola outbreak had ended. I had walked all through. And then my first pregnancy, my first baby, I was still working at this non-governmental hospital. I remember going back to the hospital and they were like, okay, you can no longer work nights for now if you don't want to. I had a fridge where I can do my breast pumping. My baby had 6 months of exclusive breast milk because of the support I had at that time. And then cue the next pregnancy and going into because I wanted to go now into a government hospital that is, what can we say, a tertiary hospital to get the experiences from there. And then the support was limited. I obviously had no private space or a fridge space to have my breast pumping piece whilst I'm at work. And as clinicians, we're at work like 8, 12-hour shifts. In Sierra Leone, we do 24-hour shifts, depending on where you're working. And imagine as a new mother having to go that long without having access to breast pump, or even if you have the time to pump in the bathrooms, you have to throw it out because there's no way to save it. And it brings to mind when we talk about African hospitals and doing research or working in African hospitals, what hospitals are we talking about really? What are the differences between hospitals? And even as and my experiences were much more better than lower cadre staff. Obviously, I had much more resources. I could negotiate as much as I am able to, and I still wasn't. And I remember talking to hospital management about this, that I can't do nights. It is really bothersome for me to be coming to work and not being able to breastfeed and not being able to pump. And I was told that you can leave the job, but because that is the job. And that is the inflexibility in the healthcare system as a woman, as a mom, that we have to talk about. And when people say it is unfair, you wonder it is unfair to whom? Because definitely not the woman. And then next slide. And then when I was told to leave, and I was like, okay, fine, I will leave. I'll prioritize my family at this time. And in Sierra Leone, we have 3 months of maternity leave, which I know is much better than some countries, even some high income countries. But 3 months is nothing if WHO says we should exclusively breastfeed for 6 months. And then the COVID-19 outbreak happened. And I was seconded at that time to work with the national response team for COVID-19. And all the learnings and the experiences, because I was in charge of the mobile team that we decided to set up to provide, so the high risk cases like people with diabetes, hypertension will not come to hospitals. And I had to add the families of healthcare workers. We had to engage healthcare workers and just ask them, what do you need? And it was simple things like provision of meals and transport, so that during this time, I don't have to think about it. And then what I learned during the COVID-19 was the stress of Ebola that I did not focus on at the time, because I had no family and children then, was exacerbated during COVID-19 because then I had 2 kids. And unfortunately, we were the first people who were quarantined in Sierra Leone when we had our first case, because we were the closest contacts to that case at the time. And I felt such crippling fear I did not feel with Ebola, that had a way higher death rate, that I felt with COVID-19, where people were recovering. But at the time, it was April 2020. The only data we had was coming from Europe, where there were high death rates. But I was working with a research consortium. So this comes to, what are the responsibilities of researchers of a research consortium like this? I had access to therapy because of the research that we were doing, because of the consortium. It was an NIHR funded something. And I took that opportunity, and it was amazing. It gave me the support I needed to be able to do my work safely and to get through that period. And it also made me realize how important linkage with mental health support is. And that was something that we immediately went to the Ministry of Health for. And we made links with the Ministry of Health mental health team to provide that support for health workers, especially those who were working in the centers. And it comes to safety. So we developed a safeguarding guidance at that time. And staff were telling us about simple things, that unlike Ebola, COVID-19 patients, they are not as ill. And because of that, female staff were being sexually harassed by these patients. And that was something we did not have to consider during during Ebola, because patients were too ill. And so staff were asking for female nurses and practitioners not to be at night, not to work at nights, not to work in isolation. And that means restructuring the rota. Imagine doing that in a country with not enough healthcare workers, if I must say, especially at a time of crisis when many health professionals were dealing with the trauma now that we experienced during Ebola. Next slide. And then it leads me now to this final one. We have a current Mpox outbreak, and we see the experiences we had from Ebola, the learnings we got from COVID-19 and how to do it better. And it's been reflected now in the outbreak that we have. There's very limited vaccines because there's just not enough. But then the public health agency is talking about prioritizing healthcare workers. There's improved relationship with hospital management and research teams. There's an increase in the ability to speak up. And that is something that shows that relationships and trust is built over time. So as research institutions, as researchers going in, we have to factor in that time to get people, especially if we want to look at intersectionalities, we want to look at gender, we want to look through the lens of socioeconomic status and poverty. It's just giving ourselves time to build these relationships. And next slide. And I think finally is the understanding that working in African hospitals, life is an everyday crisis. It's what we deal with every single day. But then when there are periods of extreme stress, it gets really, really bad, even though we are used to dealing with the usual things. So when I think about my own experiences, it just reinforces what we know and what we are all fighting for. What the reason for this consortium is that gender differences should not be an afterthought. It should be integrated into hospital operations. It should be in the facility designs, policies and practice and protocols should really understand these gender differences. And when we're doing our research, obviously right through the research process from the beginning right through to the end. I see Laetitia, so I'm dropping off now. And that is the end. Thank you for listening and enjoy the rest of the webinar.
Wonderful. Thank you. Thank you, Bintu, for a very powerful introduction. But you still have 5 minutes left, so I'm going to leave it for discussion time. But thank you so much for both setting the standard, for sticking in time, and for a very powerful introduction. Our next speaker that I would like to introduce is Professor Ivy Bourgeault. She is a professor in the School of Sociological and Anthropological Studies at the University of Ottawa in Canada, and she also holds a university research chair in gender diversity and the professions. She's an internationally recognized expert on the professions, including academia and the health workforce, where she applies an intersectional gender perspective. Over to you, Ivy.
Thank you so much, Laetitia. And I feel enormously privileged to be invited to speak today. I'm very excited about the project. And yes, I really, really appreciated Bintu's first-person narrative. And I think I will be picking up on many of the themes that she raised, from more of a research perspective. As is customary for Canadians, we acknowledge territory where we are living and working from. I'm situated near the unceded and unsurrendered territory of the Algonquin Anishinaabe Nation near Kitigan-Zibi, just north of Ottawa. And this is our 10th year anniversary of the Truth and Reconciliation Commission, and there are particular calls to action that our team and I focus on. Those are calls to action 18 to 23, 23 being increasing the complement of Indigenous health workers. It's important to know that such land acknowledgements are not supposed to be simply performative. It's really just a start in terms of situating oneself. And so I situate myself as a settler here in Canada. So the overview of my talk is I just want to go through what are the various layers of intersectionality, gender being particularly important. What are the implications of this for the health and care workforces and health systems more broadly? And then to provide an overview of some of the leading practices to support diversity and to embed that into organizations, and an open access toolkit that any of the participants are more than welcome to utilize. So as Bintu did is situate oneself, and this is adopted from Sylvia Duckworth's work called The Wheel of Power and Privilege. And you see a variety of different intersections here, sort of building on Kimberly Crenshaw's work of intersectionality. And you have different intersections of how one identifies. So I identify as cisgender, I identify as a woman, heterosexual. I live both in urban and rural areas. I grew up in a rural area. Very much privileged in terms of, from a colonial perspective, from an education perspective, from being from the global north. And I think it's important to use this as a tool to understand those different distinctions in intersectionality, but also to note that although each of these are equally distributed or have an equal size, they don't actually have an equal size in different contexts. In a multicultural context like Canada, with high levels of immigration, that will have a different set of circumstances for this wheel of power and privilege than in countries in Africa or Europe or Asia. So this, I think, is just a tool just to help open a discussion and to really sort of understand. Now, it's not completely complete. So I also encourage people to sort of think about what can be missing, but it's a useful tool to start a conversation. When you apply such concepts around intersectionality, and to be really honest, we have much more research done from a gender lens than from an intersectional lens. So it's really important to note that many of these distinctions, they're pervasive in the system, yet they are, to a certain extent, invisible. When someone has visible indications of their quote unquote otherness, or where they lie on intersectionality in terms of, religious symbols, skin color, even just accent, these are all things that make these divisions visible, but some of them are quite invisible. It's very clear that healthcare is very gendered. It's also structured along intersectional lines, so it intersects with race, with immigration status. And we've done a lot of work on migration of health workers, including from South Africa and many other African and Asian countries. It permeates one sense of their identity as a particular profession, the roles that they play within the health system, and how that differs across different systems, whether that be within a country and across countries, and gender relations, and Bintu, highlighted issues of harassment, and we'll pick up on that. Intersectionality shapes the structural location of different members of the health workforce, both within professions. So there's a hierarchy within medicine and across professions between medicine and nursing, midwifery, pharmacy, dentistry, etc. And then how the work is classified. So this is particularly gendered, but also intersectional in terms of how we think of work as caring versus curing, formal and informal, and this notion of skilled and unskilled. So that is an invisible sense. And so all of these divisions reflect the broader societal undervaluing of care work that is gendered, that is racialized, that is class, in both the formal and informal sector. So when we look at data, and I'm just bringing in data here from Canada, so the gendered nature of the healthcare system, this seems to be the only way that we collect data. In Canada, we're really quite behind on doing intersectional analyses, collecting data on race or rurality or immigration status. So you can see how the differences in proportion of women in different professions has shifted over time and is different amongst different practitioner groups. And so you have, a high of midwives being almost exclusively women, and, medical physicists, paramedics, and chiropractors having a much higher proportion of men, and how this is changing over time. So Globally, 70% of the workforce identify as women. In Canada, it's over 80%, and it's not because things have changed where professions are highly gendered female, but professions that have historically been gendered male are more likely to have women into their ranks. But this really important analysis done by Women in Global Health, the Global Health Workforce Network, and the WHO really talked about how healthcare is delivered by women and led by men. And they talked about a variety of different issues, but just specifically on health leadership, which our team at the Canadian Health Workforce Network has focused on in a specific initiative funded by Women and Gender Equality called Empowering Women Leaders in Health, was really focused on these the leadership gap, and that these are driven by gendered and racialized stereotypes, discrimination, different layers of power and privilege, and that women's disadvantage intersects with multiple other identities, as noted, and that our health systems are weakened by the loss of input from women from different backgrounds, their ideas. Like, there's a whole area of diversity in leadership in other fields outside of healthcare who highlight the importance of diversity. Women leaders bring different issues to the agenda, like Bintu has raised in her personal narrative. They bring different strengths, so they're very complementary. And so that needs to be highlighted. And so we focused a lot on that gendered but also intersectional leadership gap. So some of the recent proposals from Women in Global Health is really highlighting, again, since the publication of that report, so this is more recent, is that across all contexts, cultures, women experience common challenges for accessing leadership. There are gender norms, and as a sociologist, gender norms are what we talk about a lot, gender roles, and within the complex division of labor within healthcare. It limits women's participation. They experience discrimination linked to what is referred to as the motherhood penalty, and that tension between, roles in motherhood. And Bintu spoke very eloquently in that regard. And gender stereotypes around leadership. When you talk to someone about, envision who is a hospital CEO, envision who is a health minister, and what will conjure up in your mind, whether you identify as a woman or as a man, is a man. So we are all socialized into these ideas, as we are socialized into ideas of the meanings of racialization and rural and urban, and all of those different intersections. So there was a really interesting thought piece in a local newsletter in Healthcare. Do the people in power reflect the people that they serve? Because if there isn't that reflection, how is it that you are supposed to be making decisions that keep these things in mind? And so this is accentuated for women who identify as Black, Indigenous, Two-Spirit, and living with disabilities, and being white and settler, having those distinctions of power and privilege. Allyship is very important. And allyship is not an identity, rather it is a process, a set of activities that you need to undertake. It's important to keep in mind, important research that part of the explanation of these tensions are sort of unpaid care work at home, this notion of double duty caregiving. So we need to acknowledge that. And so this has profound differences and implications, yet it is often invisible, but it's not invisible to those who are experiencing these caregiving. When they talk about the pathway to leadership, they talk about concepts like the leaky pipeline, like you see women at the front line and see less as they move up, and particularly women of color, women with disabilities. And so rather than thinking of this as a leaky pipeline, one should think of it as a glass obstacle course. And the pandemic has exacerbated this and made it very clear. And the pandemic has long-standing implications. So there's all of the care work, but then there's also the sexual harassment and indeed violence that is experienced in healthcare, and much of that is gendered and racialized. So in order to address, we need to understand what the problems are, but we need to bring tools to the fore, and bringing some evidence-informed toolkits. And so I just want to highlight that there is what we've created with our funding is an equity, diversity, and inclusive leadership in health toolkit. We started off as being focused on women, and through the process made sure that it was also looking at other intersections. We talk about how you need to build those tools into ongoing processes for organizations. You need to set a goal. You need to align to that goal. You need to take action. You need to assess, evaluate, and reevaluate. So define, plan, act, and check, and then go through that cycle again. And that helps to create a much more diversity-aware organizational culture, recognizing that everybody who is in your organization, in your hospital, has a life at work as well as at home. How does that impact on how you schedule events, how you share some of the lesser valued work at work, sometimes what we call care work, across all members? And so that's very important. And then challenge some of the assumptions that we have. And that's a constant process. It's not like, a vaccine or being baptized. It's not one and done. You have to constantly work on that. And I just want to end off, because I see Laetitia has come on, of this notion of privilege. And I started off with privilege. It's a right that has been granted, a benefit, and in many cases, if you're experiencing privilege because of your identity, it's not necessarily earned. It's an advantage based on your social situation. And you have to move from acknowledging your privilege and recognizing your privilege to allyship. It's not an identity. You don't get a t-shirt for this. It's a lifelong process. And it's a process that you have to work on every day, because you wake up privileged or not privileged. And if you are privileged, then you have to sort of work on that. You need to build relationships based on trust. You need to be consistent, and you need to recognize that you will make mistakes, and you have to have some accountability for those mistakes that you make. And so it's really important to balance off both of those aspects. So with that, I will conclude, and I hope that's provided some important concepts, and I look forward to the discussion, and I'll pass it back to you, Laetitia.
Great, thank you. Thank you so much, Ivy. You also had 2 minutes to spare that was allocated. But thank you so much. All of you have been wonderful. And Ivy, I really appreciate some of these frameworks that you've given us, but also the particularly your concluding slides that talked about very practical ways of ensuring diversity in organizations. And I like the way that you link the individual with the organization and providing tools, and also complementing Bintu's very powerful personal reflection. So thank you for that. I'm going to move to our third speaker, who's Ms. Evelyn Kabia. She's a PhD fellow and a health economist at the KEMRI-Wellcome Trust Research Program in Nairobi. She has more than 8 years of experience in health financing, and her research focuses on health policy, equity, and gender. She's currently researching informal payments in Kenya's healthcare system, while also supporting national efforts towards universal health coverage. And Evelyn is going to share with us her empirical research on gender differences in informal payments for healthcare in Kenya. Welcome, Evelyn, and over to you.
Thank you, Laetitia. Hello, everyone. I'm going to be sharing on gender differences in informal payments for healthcare in Kenya, which is part of my PhD work. And this is going to be the outline of the presentation. So when we look at out-of-pocket payments, they are broadly classified into two. So they are formal payments and informal payments. So informal payments are those payments that are made by patients to healthcare providers. And these payments can be made either in cash or in kind, but they are above the officially determined service fees. So for example, if a lab test should be like $1 and a patient pays $1.5, this extra $0.5 is an informal payment. So you find there are different terms used to refer to informal payments, including under the table payments, illegal payments, unofficial payments, and they've been argued to exist along a continuum ranging all the way from gifts to bribes and extortion. And they're also considered broadly a form of petty corruption. So we find that according to the Afrobarometer survey done in several African countries, on average, 14% of respondents had paid an informal payment to access care at public health facilities. But in Kenya, as of last year, around a fifth of the respondents had actually paid an informal payment at public health facilities. So why is it important to study informal payments? It's because they've been linked to access and they've been shown to worsen inequities in access to care, as well as financial protection, especially for vulnerable groups such as the poor. So there are various factors that influence informal payments. On the demand side, these are patient and household factors. There are supply side factors. These are factors related to production of health services, such as human resources, availability of commodities, as well as health infrastructure. And then on the contextual factor, this is things like corruption within the public sector, trust within institutions, etc. So we find that of the demand side factors, one of the important factors is social-demographic characteristics. And of these, gender is a key social-demographic, social determinant of health. Next slide, please. So we find that gender is a key social determinant of health, and it influences health systems' needs, experiences, and outcomes. So we find that currently there are mixed findings around informal payments and gender. We find in some high income and upper middle income countries such as Russia, Bulgaria, Moldova, we find that women were more likely to pay informally for free outpatient and inpatient services. However, Afrobarometer survey done in 34 African countries showed that men were actually more likely to pay informally than women. So if I used Morgan's et al. Gender framework, which looks at gender power relations as a driver of inequality, and it has 4 main domains, which I explored by looking at this question, like who has what in terms of access to resources, who does what in terms of division of labor, how values are defined in terms of looking at social norms, beliefs, and perceptions, as well as who decides when we talk about autonomy in decision making. So we find that these domains change because gender power relations are negotiated by people, and they also vary between different contexts as well as environments. Next slide, please. So for this work, this is just part of my PhD work, and this objective focused on gender differences in informal payments, but the whole study was a mixed method study, which I conducted in 2 counties, 1 urban and 1 rural, and at 8 public health facilities, that is 4 hospitals and 4 health centers, and also within households. So I conducted the household survey as well as qualitative interviews. So for the qualitative interviews, these were done with healthcare workers of different cadres. So there were doctors, nurses, health staff working at the pharmacy, at the lab, as well as non-clinical staff such as cleaners and security officers, health facility managers, as well as managers at the county and sub-county level, as well as patients. These were patients who are seeking services at different departments. That's maternal and child health services, specialized clinics like diabetes and hypertension clinics, surgical clinics as well. So there was a diverse range of respondents. So for data collection, I used a questionnaire for the household respondents and semi-structured interviews for the healthcare workers and managers. And I used focus group discussions for the patients. So just to give a brief overview is that for the results, I'm going to focus mainly on the qualitative findings, but I'm going to share a few insights from the household survey data. So in general, we find that from the study findings, informal payments were largely considered as bribes and a form of corruption. So there was consensus among most of the respondents that informal payments within the Kenyan context were actually bribes to facilitate access to care. And they were paid for various reasons. So patients paid to receive care, to be able to skip queues and get quicker services, to get commodities, including drugs, to just get better services, and also to express gratitude. And next slide, please. So this is just a table showing some of the patient socio-demographic characteristics that are going to be important in our discussion. So this is from the household survey respondents, where we find that there were more women in the sample because women tended to seek care more often. So for the household survey, we included respondents who had sought outpatient care in the last 1 month and inpatient care in the last 1 year. Then in terms of age, for the adult population, most of them were between 20 to 39 years. And then in terms of education, most of them had attained either primary or secondary level education. But of note is that the proportion that had secondary level education in the urban county was twice that in the rural county. And then in terms of employment, most people, around half of the respondents were working within the informal sector, and a significant proportion were homemakers. Then in terms of marital status, we find that for the adult population, those who are above 18, a significant proportion were actually married. Next slide, please. So we find, according to the household survey findings, informal payments were more common among female than male patients, and they were also more common among male-headed than female-headed households. However, these findings were not significant in the regression analysis. So we find that there's a bit of contrast between the household survey findings and the qualitative findings, where the respondents felt that actually more men were more likely to pay informal payments. And a higher likelihood of men paying informal payments was associated with gender differences in terms of access to resources, such as income and employment. So we find that within our setting, men were more likely to engage in income-generating activities, meaning they had more disposable income and higher ability to pay informal payments compared to women. Then we find that in terms of health information, in terms of health service costs, was favored women because of their frequent interactions with the health system. So women would go to the hospital for delivery services, family planning, to take care of their children. So these frequent interaction with the health system made them more aware of health service costs. So they were more likely to tell when they were charged more than what they usually pay for. So health information was protective. Then another resource that influenced informal payments was time to seek care. And for men, they saw time as time is money. So some of them would initiate informal payments to enable them to return to work, but women were perceived to have more time to seek care. Then we also find that their beliefs and perceptions were associated with a higher likelihood of informal payments among men, but we find that men themselves reported that they perceive themselves as more bold or courageous to actually initiate the informal payment. And then some of the women felt that if informal payments were demanded from men, it would be shameful for them not to pay. So some of them were just forced to pay so as to show that they can actually afford to pay what had been demanded. Then we find that on the women's side, there were some factors that predisposed them to making informal payments. And one of them was the need to resume childcare responsibilities. And this is associated with the division of labor within households, where we find that women were the main caregivers, as shown in the quote, which says that, the previous slide, where a woman was saying that I'm in a great hurry. I've left my child sleeping in the house. Just do me a favor. We also find that just the frequent care seeking among women, then it meant they were more likely to be exposed to demands for informal payments. And next slide, please. So we also find that there were differences in terms of the services that were paid for informally. So among men, informal payments were mainly paid for HIV services as well as male reproductive health services, such as STI services. So this was mainly linked to societal beliefs around care seeking among men, where some men felt that men should not go to the hospital or they should not fall ill. So when they fell ill and went to hospitals, they paid informal payment to be able to get quicker services before people started asking, like, what services are you seeking? Why are you at the hospital? And then for HIV services, it was a bit associated also with societal stigma against people living with HIV and AIDS. So some respondents would opt to have the healthcare workers deliver their ARV drugs at home or somewhere else in private. Then for delivery services, this was because this was when the men accompanied either their partners or other female patients to seek healthcare services. So I think during delivery, men were vulnerable because they wanted their unborn child to be okay, their wife to be okay. And some patients felt that healthcare workers took advantage of their vulnerability as shown in the quote. So if you're having labor pains, he must pay a bribe because he wants the child and the wife alive. He gives a bribe very quickly and a big amount. On the other end, we find that women are more likely to pay for child health services, especially when they perceive that their children were in pain or they perceive the health status as poor, and also for abortion services. And this was mostly after they tried to procure an unsafe abortion. So this was also linked to the fact that abortion, even though the Kenyan constitution has a provision for abortion in emergency situations, is still criminalized within the penal code. Then we find there are also differences in autonomy in decision making on paying informally. So we find that men had the autonomy to decide whether to pay an informal payment because they were mainly the breadwinners. So they would say that I will decide whether I'll pay a bribe. But for the woman, it's what you've given her. She can decide to give a bribe. So we find that women's autonomy was limited, especially in the rural areas, because of financial dependence on their husband. So before they paid an informal payment, they had to consult their husband. So we find that autonomy was associated with an individual source of income. So for women who are earning, they could decide if they'll pay an informal payment or not. But those who are financially dependent, they needed to consult their partners or other family members. Autonomy was also associated with formal education. We find, like, especially in the rural setting, the low level of education limited women's autonomy in healthcare decision making. Then from the household survey findings, we find that marital status was an influencing factor, but we find that married patients were 58% less likely to pay informally than single patients. And this, as I had mentioned, is related to the fact that most of them, especially in the rural area, needed to consult their husbands. There was an influence on household structure. So people who were single could decide, but those who are living with nuclear or extended families, they needed to consult whoever they were living with. Then we find that next slide, please. We find that there are also differences in terms of which gender of the healthcare worker charge informal payments. So according to the survey findings, 2/3 of the informal payments were paid to men, that is healthcare workers who are men, and this was associated with men's breadwinning roles, where some of them opted to engage in informal activities to increase their salaries. And also there was some societal pressure where the public felt that if you're a health staff and you're a man and you work in a facility, then you're most likely a doctor. They expect that you earn a certain amount, so you need to live up to a certain standard. And then male healthcare workers were just perceived as more courageous or fearless in soliciting. On the other hand, as shown in the quote, female healthcare workers were perceived as sympathetic, more fearful and cautious, and they were easier to negotiate with, and also they were more likely to charge a lesser amount. So as shown in the quote, before a woman asks you for money, some will look at your financial status, others will look at how sick you are. Women are more sympathetic, but a man, they'll score, charge a bribe, but they will not like consider your situation. Thank you. Next slide, please. Then we also find that there were gender differences in terms of reporting informal payments among patients. So women are more likely to report, and this was influenced by their inability to pay. Because women were less likely to engage in income-generating activities, the little money that they have, they wanted to save it either to meet other household needs or to meet their children's need. And for those who had been given money, then they needed to account. And since bribes, there's no receipt, the only way they could account for this is to report. Then we find that women were more aware of healthcare costs, so they were more likely to push back when they were told to pay something that was above the official cost. On the other hand, men were less likely to report because of societal norms on help-seeking behavior, where the respondents would say that men were less likely to seek help or follow up on a situation, and they did that as a last resort. And then just the need for men to maintain confidentiality of the services they sought limited them from reporting, because then if they reported, then they'd have to disclose what kind of services they were seeking. Next slide. So in conclusion, we find that gender affected patients and healthcare workers' experiences with informal payments. So it influenced who had access to income, who had access to employment and health information, as well as time, and thus the ability to pay informal payments or refuse to pay informal payments. It also influenced who engage in breadwinning roles, especially for healthcare workers, and then their desire to charge informally. It also influenced who engage in caregiving roles, And those who engage in caregiving roles who are mainly women, they were more aware of healthcare costs, and therefore they could be able to push back when informal payments were demanded. It also influenced patients' autonomy in deciding whether to pay informal payments, and also find that societal beliefs determined what kind of healthcare workers solicit informal payments, as well as which patients report informal payment. And overall, in the presentation, we can see that gender intersected with different social stratifiers such as employment, education, marital status, as well as geographical location, especially rurality, to influence patients' experiences. So onto the policy considerations, we find that there's need to increase public awareness of cost of health services, especially among men, as we've seen that better awareness of health cost was protective for women. Then there's also need to address negative gender norms that predispose men to poor health-seeking behavior as well as informal payments. Then generally, there's need for continued financial and educational empowerment of girls. This has been shown to improve autonomy in decision-making around healthcare as well as better healthcare outcomes. And just the need to amend reproductive health laws, especially in the Kenyan context, to improve things like access to safe abortions, because it's been shown that some women actually incur financial hardship and catastrophic health expenditure as they attempt to procure safe abortions. Then overall, there's need for social protection mechanisms within health financing to consider other sources of exclusion as well as inequality besides socioeconomic status. Thank you. Next slide. So I'd like to acknowledge my PhD supervisors and my gender advisor, Koi, as well as the other participants for their contribution. Thank you.
Thank you. Thank you very much, Evelyn, for a fascinating talk. I'm sure there are lots of questions, but I'm going to move to our discussant, and it gives me great pleasure to welcome Professor Asha George. She's a South African Research Chair on Health Systems Complexity and Social Change at the University of the Western Cape in Cape Town, South Africa. She's also adjunct professor at Johns Hopkins University in the US. Professor George's research sits at the intersection of gender rights and health systems, and she focuses on community and frontline perspectives in low and middle income countries. She also leads the AFRHiCARE Consortium, which is a collaborative that focuses on strengthening primary health care by addressing workplace gender-based violence. And we've given Professor George the difficult task of pulling together the key insights from the presentations, and of course also bring our own research experience and insights to the webinar this afternoon. Over to you, Asha.
Thank you so much, Laetitia. It is a real privilege to be here with on a webinar sharing so many different insights and with colleagues addressing gender and intersectional dimensions. You said this was a difficult task. It's actually, for someone who really is passionate about these issues, it's a delight that we're having these conversations and connecting people so that we learn more and build momentum to really bring evidence to address these issues. So I have a few thoughts that I put together in a PowerPoint, and I've been taking notes as well, so I'm going to add a few more. But if we can go to the next slide. So these were a few reflections. We really had very rich contributions from Sierra Leone, talking about personal narratives, frameworks, and an overview from a very different context by Ivy in Canada. And then Evelyn sharing not so much provider perspectives, but insights into patient-provider dynamics and really talking about informal payments. And these are also dynamics that are happening in hospitals that we need to understand. So a real whole continuum from the institutional to the professional to the personal. A few overarching comments that when I listened to the PowerPoints and the presentations, it's been a long-standing it's been there documented in evidence since the 2000s, the early 2000s, that the health system is primarily consists of women. They are at the lower part of the hierarchy. I'm really glad we had more recently activism that really pushed a lot more advocacy by women in global health that Ivy cited. But even with that more public recognition, so the evidence has always been there. The advocacy brought more attention to this. There's more recognition, but I still think the health sector is deeply ambivalent, actually, about that we're happy to have a primarily female dominated health workforce, but really in terms of resourcing women at the front lines, empowering them to make a difference, there are many reasons why we haven't seen as much change as we would like to see. Part of this is about power relations that even closes our eyes as to what the health sector looks like, and it normalizes a lot of inequalities. So Ivy mentioned the division of labor that marks the history of the health sector, that makes us harder for us to see things that are right in front of our eyes. I only want to add further, I really liked the first presentation where there was discussion of how working as a clinician in the NGO sector was different from government. We need more research on the private sector, because the traditional research we've done is very much based on the public sector, and market forces are really changing how that looks like. And while the presenter sort of showed there was more flexibility in the NGO sector, we really there's a whole research agenda. The private sector is very diverse, and that was a positive example, but there are a lot of examples that show very worrying trends in the private sector, and a deep sort of informalization, further informalization and task shifting that has gender elements to it. I think the presenters also showed, I mean, the personal is political is a longtime feminist frame, but what was striking to me is somehow we still don't talk about that in our professional, in the professions, in the workplace, and the reflections on what it meant in terms of being a mother and working in the health sector as a health worker. What really struck me about that narrative is also the long-term effects of experiencing discrimination. It's not a one-time event. It might happen in specific events, but the memories of what happened come back to haunt us. And so we don't have research that's longitudinal, that track these over time, but we really need that kind of research, because you could see that people remember things, hold on to things. They don't have spaces to process the trauma they face as health workers, the pressures they're under, and then that has implications. So it's sort of iterative over time, some of these gender dynamics. And there is research to show that women process these. They might have, I wouldn't say they have the same exposure, but even when exposed to stressful events, women process that in a very different way than men, or if you take an intersectional lens, cutting across many different types of disadvantage. And that has harmful effects as well. The way we process stress, respond to stress, can have deep implications for health as well. The other thing I was struck by, and it's not in the slides, but the presenter finished with, it's every day is a crisis. What I thought about that was there's actually never a good time to address gender issues. I think we have this assumption that we're working for an ideal health system. So once we're done with crisis, then we can address these underlying things, there's never a good time. And the sooner we recognize that these gender dynamics are key to strengthening our health system, the sooner we'll move towards addressing that. And it was just good to be reminded about that. And I really appreciated the references to mental health. We don't talk enough about, I mentioned it earlier, the gender differences in mental health, what that means in the health professions, and what resources are there. What kind of systems of care do we need to have for the carers themselves? We do have, in the health professions, we talk about burnout, people leaving the health workforce, but I don't think we've really addressed in our occupational and wellness the mental health issues and the gender elements of that. When it comes to money and the presentation from, sorry, not money, one thing that Ivy presented, she presented a range of tools, which I thought was really helpful. One thing she had in her earlier presentation that didn't come through that I felt was an important thing. Part of understanding gender and critically reflecting on gender as a power relation makes us rethink what the problem is and what the solutions should be. So there's been a lot of talk about quotas for women. Are they effective or not? And Ivy didn't get a chance to present this, so maybe in the Q&A she can come back to this. But I thought it was interesting. She presented, she did present on the webinar, but in her previous slides, she had a slide on, should we be doing research on quotas for men? And put a cap on how many men we have in leadership positions and really check whether, what kind of talents do we need at the higher levels of the health system. I thought it was a very interesting way of thinking about it, that we haven't been able to do work on that because we're so focused in looking at quotas. How do we fit women into the system rather than changing the system? Coming to Evelyn's presentation, I thought it was a wonderful, so much data, quantitative data, qualitative insights. It was an excellent presentation. And it just reminded me in a simple way, money is not just about money. It's deeply symbolic and it's about power. And I think her presentation really showed how the negotiation around informal payments and how healthcare seeking is deeply symbolic and is about how privilege is exercised, entitlements are exercised, and how two people have the space to negotiate or not. I thought it was interesting, the finding that women were more likely to report informal payments. And this leads to broader research. There's been, in the governance space, there has been a line of research to investigate, are women more corrupt or less corrupt than men? And some of the findings, the last time I looked at that work, really showed it wasn't that women are innately less corrupt. They were just less embedded in systems of power, in networks of corruption. And I think here the research that showed that women are more likely to report because they really needed the money and they couldn't put up with a corrupt system. So for us to even look at the findings and dig a little further at what lies behind that. But really the presentation also showed the many ways in which patriarchy holds on to power and justifies inequality. So the qualitative perceptions of men could afford more, it was more stigmatizing not to have money. All of that shows you insights as to things that we need to address and change. I wanted to end with just a few slides, taking advantage of that we're here to add one other dimension to gender dimensions in hospitals that Ivy flagged in terms of sexual harassment. I wanted to talk just briefly on workplace violence. It is deeply gendered. So we have now updated systematic reviews that WHO will publish hopefully later this year. But 62% of health workers have an experience of violence. Male health workers and female health workers have very experienced different types of violence. But what's striking is that verbal abuse is something that female health workers are more likely to face, and that's so high in the health workforce. So there's a lot of scoping reviews that are coming out. If we go to the next slide, even I put a slide on the emerging understanding. I'm really delighted that from 2007, when I first reported this in a systematic review, there's now more recognition of the gender dimensions of workplace violence. And there's been 2 scoping reviews that have come out from a group in Canada looking at the gender dimensions in the health workforce. So I'm glad this is coming back into attention, and the Lancet also had a editorial on it based on the death of an Indian health medical doctor 2 years ago. If you remember that incident, I think it really shook everyone. And it's important. It's an area that is so normalized. We haven't been looking at it, and we need to look at it. I'm just going to end on the slide of our consortium. What are we trying to do? We've just started. I'm delighted to be working with amazing colleagues from Burkina Faso, Tanzania, and from the city of Cape Town to really look at how do we strengthen primary health care to address gendered workplace violence. And this is just the framework we initially developed. And the reason why I wanted to show it is a lot of work on gender focuses on the micro level. Ivy mentioned identities. We tend to think of gender at the interpersonal level as something that's experienced between individuals. It actually cycles from the micro level to the meso level and the macro level. And what we're trying to do is shift the research agenda, that we need to look more at the organizational systems. We can look at the individual experiences of gender, but we have to change organizational culture. We need to change the way we think about risk. It's not individual risk alone. It's what are the ways in which the health hospitals are structured that lead to risks and exposures that need to be changed. What are the system capabilities that we need to challenge if we need to address these gendered vulnerabilities? And then looking more broadly at the broader universal principles. The intersectional roots really come from a structural level. And if we don't understand that broader context, we're not going to be able to address these issues. So I know I'm over time, but I wanted to show this image, not just to showcase there's more work to come, but really how do we move from this focus on norms and the individual to actually organizations, how hospitals are run, the meso level and the macro level, to really address how gender and intersectionality functions in our health systems. Thank you, Laetitia, and others.
Great. Thank you so much, Asha. And in fact, your last comment, that's AFRHiCARE will begin to kind of chip away at that concrete on looking at the hospital as an organization and how these issues of gender and intersectionality affect both health workforce outcomes, but also patient care outcomes. So thank you so much for that. Colleagues, it's been a very thought-provoking and very interesting hour and a bit that we've spent. I'm going to move straight. I want to give each of the panelists an opportunity to make a concluding comment. Evelyn, if you can also, you and Bintu, if you can also put your cameras on. I'm going to go straight away to the questions. So let me start with a question that was in the registration to Bintu, and to Bintu particularly, how are gender issues affecting health research, and how should we begin to address these gaps? I'm going to give all the questions and then give you an opportunity to address these questions. There are two questions for Ivy. Ivy, the one is, how can African hospitals adapt gender and intersectionality indicators to reflect local realities while keeping them measurable and useful? And then another question which you started to address in the chat, but perhaps you can just talk about that, was that people wanted you to just explain why is there an objection to the leaking pipe syndrome or notion. So those are the two questions to Ivy. To Evelyn, there are also two questions. Evelyn, the one is, what role does gender play in determining health-seeking behavior, and what steps can be taken to bridge these gaps? Then there was another question to you. How do we ensure gender-responsive social protection mechanisms so they promote equity? Do you have any suggestions for that? And then a question from me, Evelyn. A third question is that in your presentation, I was fascinated by the contradictions between the sort of qualitative perspectives of your study participants and what you actually found in the survey. So can you maybe just, what are your insights on what explains these sort of differences in perceptions? And in your findings, and then I have a question for. Then there was another question that was posted into the chat, which is to Ivy and Asha, which is, to what extent does the professional identity of nurses reinforce the gender mix? And to any of the panelists, has there been, what is the sort of existing evidence on patient preferences for the gender or of the health workers? So those are kind of two questions. And then I have a question to both Asha and Ivy, which is that around the both of you talked about kind of broader organizational interventions. And Asha, you concluded with your slide on what you're trying to achieve in AFRHiCARE. You also talked about the need for further research on quotas, but I wanted to ask if you and Ivy could comment on the current backlash on, diversity, equity, and inclusion initiatives, particularly from the US. If you have any comments, and what advice would you give to researchers at this point in time? So that's quite a mouthful. And if we can maybe start with you, Bintu, in responding to the question, but also if you want to make comments on any of the, if you want to comment on the other questions or on the panelist observations. Over to you, Bintu.
Thanks, Laetitia. And the question was about the importance of gender in health research. And I think even if we go back to historically, gender, there has been very little research on just women's health issues. Even if we look at it looking at clinical trials, we still don't have answers for things like endometriosis or menopause. There has been great interest in recent years about funding women's research. So it goes all the way back to that. And Asha and Ivy and Evelyn, they've all given us data to show that when it comes to healthcare, men are the leaders. So when we shape research to actually interrogate health systems, if we want to talk to the leadership of health systems, that means we're talking to men. So how do we ensure that the answers we are getting about health issues have the voices of women included? So which is why we're here and we're saying, when we are discussing research, it is very important for gender to be included right through the design and understanding the barriers that women face, the challenges, but also the powers that women have in the health system to make changes. And just a comment before I leave, it's just the importance of research institutions to understand that. And as I said, build those connections put in those resources, because most of the time the women we work with, the health professionals we work with, the patients we work with will not even know what to ask for, will not even know how to ask for therapy, for example, how to ask for our research times not to be in the evening because they have to go cook dinner, but they want to be present. So it's just important when we're designing our research and analyzing gender that we take into consideration all of these things. And I think I'll stop here. Thank you.
Maybe I'll go next, and because I think a visual is really important, I'm just going to share a visual about the leaky pipeline. So I'm hoping that you are seeing that. It's a visual that was developed from specifically focused on women in academic medicine, but I think that the visual translates. So basically, the leaky pipeline, which is pictured in the background here, is that you have women who enter into medicine and they're less likely, to become full professors, department chairs, and deans. And even in Canada, a place that is considered, very focused on gender equity, we have only ever had in the history of Canada 10 female deans of faculties of medicine. And there are 17 and soon to be 20 medical schools. So again, I'm counting them on my hands. I may have moved to my toes in the next little while, but that's pretty remarkable. So that's what we're talking about in terms of the leaky pipeline. And the leaky pipeline makes it sound like it's gravity, that people are just following through the pipe. But at every single stage here, people are actively pushed out. That's why this glass obstacle course is trying to navigate that, and family life, like Bintu described, and having be faced with the position of, stay in the job or don't stay in the job. And so that's, particularly problematic. And that has a case in terms of if only 18% of your deans, and that's roughly the way that it is in Canada as well. These are older data from the United States, but it has an impact on curricula, right? And in order to change curricula, you have to have a sustained presence of women. And then we're just looking at this from a gender lens, right? I mean, it would be very interesting to look at this with, some intersectional data on, gender and racial identity, which they may have in the United States. So I'm just going to stop sharing that. And I want to come back to, I think I was really focused on maintaining my time, and my apologies, Asha, that I didn't get to the slide. But I think it also speaks to, the issue of, targets and quotas. And so I think what happens is when you have targets and quotas and the focus is on the group that is not privileged, then those are things that are easy to remove. And that's why, and that kind of speaks to the issue of the backlash in the United States, because the focus is on the folks who are not privileged, who are diverse, etc. And what I really liked, and I'm hoping that you're seeing the slide about reverse targets and quotas, that it puts the focus not on those who are disadvantaged, but those who are privileged. And I think it shifts the conversation, it shifts the reframing. And what's so interesting is I haven't seen this, implemented. It was an idea presented in this political science article. And I think what it does is it changes the focus to truly meritocracy, and how you have to change the criteria, and it kind of with the hope that it neutralizes, especially in sort of leadership circles, and that notion that masculinity equals leadership, or leadership embeds masculinity, which has an impact on women acting more masculine in order to get into leadership positions, but also that notion that leadership is only about your position in the hierarchy. And it's also about getting folks to lead from where they are, which helps advance women forward. So those are a few of my comments. I will just conclude by saying I feel for colleagues in the United States that have implemented initiatives and have gone back 20, 30 years, that programs are being dismantled. My research chair at the University of Ottawa, gender diversity and the professions would simply no longer exist. And so I'm very mindful of that. But even more so, I'm mindful about how these policies that are anti-DEI or EDI affect global health initiatives. That I think is particularly egregious, and we all have to stand up and speak about this where we can. So I hope that that's answered the questions that you asked, Laetitia.
Thank you. Evelyn, over to you.
All right. Thank you for the question. So I'll start with the first one on what's the role of gender in influencing health-seeking behavior. So we find that it influences, for example, division of labor within households. So in our case, we find that women are more likely to engage in caregiving roles, that is taking care of children. So we find they more likely to take the children to the health facilities, means that they have frequent interactions with the health facilities for themselves, for their children, for other people that they're taking care of. And we find that in our case, then this made them more aware of healthcare costs, which was protective against informal payments. But we find that this is not the case for all the women, where we find that women with the lower levels of education, they tended to have lower awareness of healthcare costs. Then you also find that gender influences who engages in income generating activities. So you find that where men are more likely to engage in income generating activities, then they opted to forgo care or seek care from over the counter so that they can continue to earn an income to meet their breadwinning roles. Then we also find that gender also influences things like autonomy in decision making around care seeking. So for example, in a study which is not related directly to informal payments, we find that women, especially in the rural areas, they had to consult their husbands before they sought care or before they allowed a healthcare provider to maybe perform a procedure on a child. And so these kind of influences whether people seek care and utilization of healthcare services. Then the other question from Sally was on how best to ensure gender responsive social protection mechanisms so that they promote equity. So I think generally we find that social protection mechanisms tend to focus on socioeconomic status as the main driver of inequity, but we need to look at how other factors such as gender and other social stratifiers contribute to inequities in access and vulnerabilities in terms of accessing care. So for example, we find that in our study from the household survey, we find that people with chronic care were 3 times more likely to pay informal payments. People in urban areas were 2.5 times more likely to pay informal payments. And we've also seen that among men, just the lower awareness of health information and healthcare costs made them more vulnerable. So instead of just focusing on socioeconomic status or having programs that target the poor, we also need to see what are these other drivers of inequity that also predispose people to being more vulnerable and contribute to inequities in access. Then on to Laetitia's question around the mixed findings. We find that, so for the household survey findings, they showed that women were more likely to pay informal payments than men. However, these findings were not significant in the multivariable regression, and this could be because women were overrepresented in the sample. So we find that in the regression analysis, women accounted for around 72% of the sample. That's why maybe the findings were not significant. And that's where the qualitative findings try to help us understand who are more likely. And that's why I think the main factor contributing to ability to pay informal payments is just that access to income or employment. Yeah, thank you.
Thank you so much. Just the last question, either Ivy, Aisha, there were also some questions to you. Over to you, Aisha.
Thanks. There's so much to say. I think it would be great, Laetitia, if you bring in your perspective on nursing as well, since you've done so much working on the professions. I think I don't have an answer to that. I think obviously the shaping of nursing as a profession historically has differentiated doctors from nurses, with nursing being caring and doctors being curing, and that being historically the divide that also led to lesser recognition, lesser pay. So that's historically what's happened, but I feel like there's a lot more has happened with the shaping of nursing as a profession in each country. And I know, for instance, in India, where I'm originally from, the nursing profession was very much against creating a pathway for community, for paramedic auxiliary nurses to have a pathway to becoming professional nurses. So it's not always, the biases are not always across the gender binary. It can be women in health professions themselves stopping other female health professions from climbing up the career pathway with the formation of health professions. I think we need more research in each context. The formation of the health professions is a political process in each country. And rather than making broad generalizations, is understanding what that looks like. In West Africa, we have a lot of male health workers, actually, in certain categories that you don't have in South Africa. So I think we need yes, gender and intersectionality is a form of power and discrimination that is universal, but how it is expressed, we need to look at specific contexts and come up with solutions that are owned in that local context. And I think once people see the relevance of it, and not as something that someone else is pointing out, and I think you saw that in Bintu's presentation. In all my work, once you start talking about these issues, you sort of open the lid, and there's a lot of people who can recognize what the dynamics are. We need to elevate their voices and have them leading the process of change. And I think the more that's done, the more that those solutions become more sustainable. And I think that's, for me, the backlash in the US. We need more African voices leading change on this issue in Africa. And it's a political process. The US, in my view, they have to deal with gender issues in their own country. But our solutions here can't come from there. Our health professions, the reforms that are happening in our health systems are different. And the more we elevate African voices, the more and how they speak to our context, the more legitimacy this will have, and the more people will see value, because it's linked to making their health systems work better. Over.
Great. Thank you so much, Asha. There's clearly quite a lot. Asha, Ivy, you've posted something into the chat. I mean, your chair also focuses on the professions. It seems to me that we could almost have a second webinar where we only focus on gender, intersectionality, and the professions. And that could be another focus area. But I promised you that I'm going to try and finish on time, because I also value your time. And so I'm going to give each of you, and I'll start with you, Aisha, just one concluding comment. I'm going to work my way backwards. So Aisha, I'll start with you, and then we'll conclude with Bintu, and then I'll just make a few my key take-home messages from the webinar this afternoon, and we will then conclude the webinar. So Aisha, over to you.
I think hearing the voices of health workers in their own context, highlighting what are the pressures they're facing, and how do we work as teams in those contexts, in hospitals, in primary healthcare clinics, is key to highlighting what are the gender issues and developing solutions for that. So thank you.
Evelyn?
Yeah, thanks, Laetitia. So I think there's value in incorporating gender and intersectional analysis in health systems research, including health financing research, especially to ensure that social protection mechanisms are more effective in terms of increasing equity to access, especially for vulnerable groups. Yeah, thank you.
I will just note, I just want to echo the importance of how context matters. So I'm really excited about this initiative and to see how African research will help us understand more fully the gender dynamics. And I'm excited about that. So Bintu.
Thank you. Thank you, Ivy. Bintu?
Yes, thanks. So just leading on from Ivy is cultural sensitivity. So as we're conducting these researches, as we're talking about intersectionality, we're coming in from a place of power, from a place of education. And even though we may have so many PhDs in the room, we do not have all the answers. And we are not the ones who are supposed to make the decisions that woman in the village with no formal education knows her solutions. And so just for us to be aware of that and include that in our work and understand that. Thank you.
Thank you so much, Bintu. And that leaves me to just, first of all, thank all of you for your excellent presentations. Yingxi has put in the chat that we will post the recording after we've edited it, just a little bit. Then I want to thank Yingxi, who's done all the heavy lifting to make sure that we have the webinar this afternoon. I also want to thank all the participants, and then I just want to thank you for certainly the learning that I got from all of you this afternoon. So if you may, I just want to highlight key issues. And yes, Aisha, I see your note here about French, and similarly we would need to include Spanish if we want to also address Spanish Portuguese, because there are certainly some Lusophone countries in Africa. So yes, that's an issue that we also need to look at. But I just want to say thank you to you for the learning that I got this afternoon, and maybe just share with you my key take-home messages that were highlighted by a number of you. So Bintu started off by highlighting the importance of context and sharing the experience of 3 different kinds of epidemics. Starting with Ebola, then moving to the lessons from COVID, and then also now the more recent example of managing mpox in the context of Sierra Leone. But I think it has relevance for all of us. And one of the things, so both Ivy as well as Asha picked up on the issue of context. But one of the things that I also want to highlight that you noted, Binu, was just that issue of relationships and trust, and that it's sort of built over a period of time, and that we all need to recognize the importance of that in the health system. Ivy, I like the way you highlighted that recognizing that one of the key things is to actually recognize and talk about your own positionality. Both the privilege on that diversity wheel, that you could be at different levels, different types of privilege on that wheel. But as researchers, we need to be acutely aware also of our own positionality, that we need to recognize the gendered nature of health work, which is not only about identity, roles, and relationships, but also about the relationships and the overall societal valuation for. So thank you for that. And you also highlighted that if we begin to move beyond some of the things that we know already, we need to begin to measure not only measurement on gender, but also take a true intersectionality lens in, in doing gender and intersectionality research. Evelyn, I really like your very, very complex and very comprehensive study. One of the key messages for me is that as a researcher, we should first of all, we should use multiple methods to address our research questions. The value you highlighted, the value of qualitative research, and you're a health economist, so health economists tend to be very, quantitative, but I think also around making sure that you do empirical research and that you don't make assumptions, but rather let your data do the talking. Asha, thank you for pulling everything together, for highlighting the importance of language certainly as a measure of inclusion, also for highlighting the issues around power, and again the sort of intersectionality, if I can call it that, of the micro, the meso, and the macro levels. Certainly, as a team, we will reflect on what is a very rich seminar. But please, if I can say thank you again for the time that you spent on preparing for the webinar, for actually sharing your insights with us, and certainly for making us, giving us a lot of not only food for thought, but also additional research questions. Thank you very much. And have a good day or a good evening, depending on which time zone you're at. Thank you.
Thank you.
Thank you. Bye.